Good morning, everyone. Welcome to this Take-Home Messages Best of the AUA Highlights. It's a pleasure to have you join us this morning. We're going to be spending about 20 minutes together going over the BPH highlights from this year's AUA 2025. We invite everyone to come into the room and have a seat. So we'll begin with some introductions. My name is Dean Elterman. I'm an associate professor at the University of Toronto in Canada, specializing in BPH and functional urology.
And my name's Bilal Chughtai. I'm also an associate professor at Northwell Health in New York.
So let's dive in here with our first slide. We're going to take you on a bit of a journey. We're going to have some topics. The idea here is this for Bilal and I to be a little bit conversational. So we're not here to go through every single abstract, give you every single detail. We're going to highlight some high level, some of the takeaway messages, some of the key findings, and then we're going to have a little bit of a discussion around different technologies, different categories, what we're thinking in the field of BPH, what's on the horizon. And so hopefully you'll be able to take away a little bit from our conversation, not only about what was presented here, but certainly how the field is evolving and the direction that it's going to be taking.
All right, so we're going to get started. I think overall, so the first thing that when we got invited to speak on this topic was just looking at the overall abstracts altogether. And what we saw is that there's a lot of excitement in this field, a lot of innovation in this field. We're seeing over 100 plus abstracts dedicated to BPH and innovation in that space. There is an emphasis on some of the minimally invasive therapies and patient outcomes. And I think, as we know, since it's a quality of life condition, patient outcomes are an incredibly important part of it. One of the things that we also did is we plugged in all the BPH abstracts into a model and seeing what the distribution is. And what we can see is lots of prospective trials and real-world evidence.
Yeah, I think there's really an increased interest in how these technologies are first being studied and then how they are actually performing in the real world. So we're increasingly seeing longer-term data being collected in the community, in large group practices, in academic centers that will either reinforce the original findings from the pivotal studies or maybe give us greater insights. And so I think this shift from blue to green is really interesting. We're still seeing a lot of the prospective studies done in major academic centers, of course, but the real world evidence for a lot of BPH is gathering. And we're going to show you some of that here today, because as you know, a number of these new technologies for BPH have come onto the market within the last 2, 3, 6 years. And now we're really seeing them used in clinical practice. So that's, I think, been a really remarkable step forward.
Agreed. So we're going to move on to one of the areas that I think the AUA did an incredible job on was highlighting clinical trials. And one thing I also want to just give a disclaimer of: if we missed an abstract, it was accidental. We tried to be comprehensive and cover what we could. So one of the areas was covering clinical trials of like these novel stents and additional trials on HoLEP, comparing a variety of HoLEP techniques. What's neat about what we saw in this session was that these are trials that are up and coming. They're sort of like just starting to recruit. And I think it's great to see that highlight to expect their eventual data.
Yeah, so the AUA has done something new, which is doing this trials in motion. We see it sometimes in some of the journals now as well. And the idea is to sort of be able to track from trial design, what's being done, and then you're going to be able to see the evolution presented year after year at the AUA, those early first-in-human studies, those pilot studies, the pivotal study, et cetera. So here we're going to go through some of these new prostate stents or first-line interventional therapies that you can see on the side there in detail. But a lot of these are now ongoing studies with patient recruitment, the data is maturing, and it's a really exciting time in the field of BPH.
So, as we initially alluded to, this is one of the first abstracts we want to discuss. This actually looks at the AUA BPH data set. So basically, the AUA registry looks at MIPS, and you're able to identify cohorts of men who are undergoing procedures, medications, and in this real-world data set, there's about 1.6 million men, and this is presented by Dr. Rohrborn and Lori Lerner, and what they saw was interesting was the utilization of IPSS in the real world setting. So ultimately, if you look at the numbers, they're still very impressive numbers in terms of like the number of patients on a variety of treatments. But despite that, the original number of 1.1 million people in this data set, and out of this data set, only 14% had real usable IPSS to report on. So I think that that's going to be a challenge, and we do have to encourage our colleagues and ourselves to hold a higher bar. Like we are using IPSS as our gold standard.
Bilal, I think, with these data sets, the AUA has done a great job being able to collect and create something like this, and we can interrogate it. But with any data set, your data that you can extract is only as good as the data that comes in. And even if we have guidelines that sort of recommend or mandate collecting IPSS symptom scores, if we're trying to look here for real world outcomes and there's 86% of the patients missing these scores, it really limits our ability to interpret this type of data set to make meaningful conclusions.
Agreed. And I think it's one of these things that I think we have to understand a bit better and how to encourage that, because as we're learning, the BPH journey is not a patient presents, gets an intervention, and then disappears. This is a patient that's going to require follow-up. Some of these treatments seem like they're going to have a lifespan, and then you have to follow these patients in terms of like what symptoms come back.
But what we can see from this study, to be fair though, and that was the main takeaway of this abstract, is that you can see here that real-world data does consistently show outcomes similar to the clinical trials. And so I think that's really important. We're actually seeing lower emergency room visits, lower hospitalizations post minimally invasive therapy. So, in the real world, people are getting better technique. These are being instituted into our armamentarium. The word is used a lot, the offerings that we have for BPH. And so, at least it's very reassuring that in the real world, when we are doing these new types of procedures, we're able to at least mimic and match what was done in the clinical trials.
Yeah. And lastly, I think we're also seeing this shift from medication to procedures. And I think we're seeing that these procedures are having better outcomes than palliative medications, which I think segues us to our next slide.
So this is from the IMPACT randomized trial, and this is a prospective randomized study between prostatic urethral lift, UroLift, compared to tamsulosin. And it was designed as a one-to-one randomization with a primary endpoint at 3 months, looking at IPSS improvement as the primary endpoint. And it was a crossover design, meaning that both arms could choose to cross over. So if you were randomized to the alpha blocker group, tamsulosin, you reached 3 months, they took your data, you were offered the opportunity to go over and get a UroLift. And vice versa, if you got a UroLift, you could start an alpha blocker if you wanted. And then they followed them out through 12 months. So here are some of the, before we actually go to the findings, I think, Bilal, what do you think about this idea of doing a minimally invasive treatment, randomized controlled trial against the standard medical therapy?
I think that's what we need more of. I think it's very clear that lots and lots of men are on medications. We are seeing that there are some concerns with medication, potential side effects, and in addition to that, a lot of patients, as we all get older, are put on medications, and they'll present to the office saying, "One more pill." So I think this type of data really shows us how these minimally invasive therapies shape how they're shaped into our guidelines and how to move these patients forward.
So, one of the things about minimally invasive therapy is that we're trying to move men in some large part off of medical therapy for a variety of reasons. But we have to do the research, really putting them in the same study head to head to know how they fare one against the other. So we're going to show you here some of the results from the IMPACT study. So prostatic urethral lift pull patients, IPSS improved by 40% and 46% at both 1 and 3 months. The medication group only improved to a lesser extent, 18% and 15% at 1 and 3 months respectively. This is very significant. And notably, the patients who chose to cross over had significantly less IPSS improvement during those first 3 months. So there's a significant amount of dissatisfaction amongst patients receiving medical therapy. And when they were offered the opportunity to cross over, the vast majority did, and those who did cross over were more likely to have not achieved their goals, not achieving their improvement in symptomatology. So I think this is a really dramatic splitting of the bars here in terms of the amount of improvement you're seeing with a missed in this case, prostatic urethral lift versus medical therapy. What's your takeaway on this one, Bilal?
Agreed. I think this is the kind of information that we're able to utilize in our practices to really counsel our patients in terms of, look, I've got a medical therapy to offer you. This is the improvement you can expect in terms of symptoms, but I also have a therapy for treating the underlying condition, the prostate itself, and this is the options we have and the outcomes expect.
So we'll just move through some of the other data where we want to make sure we get through all of the different studies. So secondary outcomes with respect to sexual function. Again, this is really where you see the divergence between medical therapy, alpha blockers, and a minimally invasive therapy. Remember, MISTs really try to emphasize preservation of sexual function. We really don't see significant changes in IIEF and MSHQ, erections and ejaculation. And once again, we're able to demonstrate in this impact study how those bars really separate. You're seeing significant changes more likely in sexual function with medical therapy, and in fact, stable or even improved sexual function in those men receiving a MIST.
Yeah, and again, just highlighting the fact that the change in sexual function is very important, especially when starting alpha blockers. All right.
So we're going to shift over now to some of the presentations that really were looking at this novel class of prostate, we'll call them prostate stents. And this class, we've sort of introduced this term as first-line interventional therapies, or FITS. So FITS is really this new category somewhere between medical therapy and MISTs, minimally invasive surgical therapy. And the idea that we propose with FITS is that these prostate stents and these types of procedures are going to be, number one, able to be done in the office setting, flexible cystoscopy, improving symptomatology, and they're fully reversible. I think those are some of the key features of what a FIT is going to be. So generally, the minimally invasive therapies now are done with heavier degrees of anesthesia, and they're all done really with rigid scopes. So we're seeing a real renaissance or a reemergence of stents 2.0, very different than what we saw 20 years ago with materials in nitinol and the way that they're designed. So we're going to take you through some of the FITS that were presented here at the AUA 2025.
Yeah, so one of the first ones that was a late-breaking abstract was the Pro-V system. This is a permanent nitinol implant. Here we can see the components that go to it. The trial they showed their initial data. We'll look at the trial design here, and we can see that this is their trial design, and we only had, there were only, 90% of the patients did make it through to the 12-month data, and we can see an image of the actual stent itself. It's on the left side of the screen, and when we look at the data, what's really notable is that you've got this improvement of IPSS over time, and you can see what happens to the sham group, and this result was sustainable up to basically out to 1 year with a 40% improvement in symptoms. I think it's remarkable that they had such durable outcomes.
So this is an important, almost landmark abstract presentation. Why? Because this is the very first of this FIT category to have their pivotal study present the outcomes. So this is the 12-month outcomes, first time ever being presented at the AUA. So this is the type of data that will be submitted to the FDA, for example, for approval and commercialization in the United States. So they were able to meet their primary endpoints at all of the different time frames and the outcomes.
Yeah. I think what's also notable is that this is a pretty severe group altogether. Look at their IPSS score with a baseline score of 24. Now, we can also look at Qmax, very similar improvement as well, and still durable out to 12 months.
So there were a number of other FITs that were presented. I'm going to take you through some of them. This is the ZenFlow spring system. So this is the pilot study, not the pivotal study, but we had 36-month outcomes from the ZEST study. This was combined from 4 different countries. It was a pooled analysis, and you're able to see a fairly rapid improvement in symptoms as soon as 2 weeks, maximizing around 4 weeks, and sustained out through 3 years with this different type of minimally invasive treatment. And here you can see over the 3-year results. This is some of the longer results that we've seen in a pilot study. 46% improvement in IPSS, quality of life improving, peak flow, and the responder rate was around 75%, which I think is very acceptable, very similar to other minimally invasive treatments as well. This is the Rivermark flow stent. This is an American stent. This is the Rapid 2 pilot study. The Rapid 3 study is now recruiting in the United States. This is a unique stent in that it is designed to be implanted using any flexible cystoscope. There's no proprietary system. Again, this is over 4 centers, and you can see on the next slide the significant improvement in IPSS. And I think the real takeaway, at least with the flow stent, is that it's easy to put in with a universal, any scope, and it's easy to remove. And you can see there at the 52-week mark, a 51% improvement in IPSS.
Yeah, and here we have the Eurocross expander system, another novel stent. This one's unique in that there is a fixed time point where it's removed approximately 6 months later. And when we look at their study design, this is a 3-arm study up to 12 months, looking at dwell time for the stent. And here we can see again, we've got this rapid improvement with the stent in place, and then you have you have the same improvement after the stent was removed as well. And I think this really bridges us to, on the novel stents that are there.
I think this is really promising. We're going to see where this direction goes with respect to these fits, but certainly we're seeing the early evidence demonstrating their efficacy, greater than 50% improvement in IPSS, flow rates improving, and we're going to see whether this shifts the paradigm to a really more competitive intervention relative to medical therapy. So we're going to move on now in the interest of time. These are the currently available approaches. So we're going to talk about things that are already FDA approved, that are currently on the market, and see what's new with them.
Yeah. So here we're basically highlighting the fact that our current decision tree is based on prostate size. That's essentially how we're approaching prostates right now. But I think a lot more has really come up. And one of the notable studies is done by Ricardo and his group, looking at the fact that looking at 1,000 men, looking at what was important to them in terms of determining for prostate surgery, and ejaculation turned out to be one of the #1 things that they're looking at.
So I think this is interesting. This was a sample of 1,000 random men. They're not patients. They don't have BPH. So it's a little bit of a different question we're asking of a different patient population. But if you ask just men on the street what is important to you, they're actually going to rate ejaculatory function preservation as being really important in the decision. And so I don't think we can take it for granted that whatever we offer men, you can't ask them if it's important with respect to their values with respect to keeping ejaculatory function.
Yeah, and here we're looking at long-term studies. So ITIN, one of the first of the stents that were available, designed to be in place for about 5 to 7 days. We have data out to almost 3 years, and showing an IPSS reduction of about 50%.
So this is similar to what we were talking about before. We need to not only have these devices in the commercially available, but be able to follow them over the longer term to see how they work. After the iTind, we now have the Optilume BPH system. This is the most recent FDA-approved BPH treatment, and this year was presented the 5-year results of the first in man. So this was a single-arm study called the Everest study, and what we're seeing here is a sustained improvement with a responder rate close to 80% even at 5 years. And on the next slide, you'll see here that rapid improvement in IPSS greater than 11 points, sustained out through 5 years. So this is a long-term follow-up. And notably, we have a low reoperation rate of 1.3%. And we'll also see the significant improvement in Qmax seen quite early with the Optilume BPH, and so now sustained out through 5 years. The US study has been presented also this year, and it was sustained out through 3 years. And so here we also see preservation of sexual function with the Optilume BPH all the way out through 5 years as well.
Yeah. And also for aquablation, we're seeing long-term data, real-world data out to 24 months. This is their baseline characteristics and preoperative characteristics, but I think notably we're seeing a very similar pattern and improvement in IPSS and quality of life. I think the big thing to take away from this is that in the real-world setting with even very large prostates, you're seeing a low retreatment rate on the order of magnitude of 1 to 2%. And in addition to that, patients on post-op medications, in the real-world setting, about 1 in 5 men did restart some medications.
So I think this is a notable study because aquablation has now become really entrenched in U.S. market. We're seeing an increasing number. Utilization is projected that by the end of this year, 20% of BPH resective surgeries will be done by aquablation. And so I think it's really important not only to look at the published literature, but what's being done. So this is a cohort of multi-center real-world data collection. I think is 1,900 patients, and that you're able to see reproducibility of what was seen in the clinical trials in the real world. And so I think the operative time is reasonably short, the aquablation time being 7 minutes, the complication rates being very, very low, and the IPSS improvements being sustained with retreatment rates also being around 1.5%. And so, we're trying to take what's being done in the real world, what's being done in the United States, and really compare that to clinical trials. And I think it's bearing out, certainly with aquablation.
Yeah. So I think to overall summarize, I think the things to think about is that in the AUA, we saw a lot of new, exciting things. So question becomes really for the audience, like, what are new BPH therapies you're going to bring back to your practice? And I think for me, it's a lot of thinking about these first-in-line therapies. I think they're very novel, new. They fill a unique gap that patients really are asking for.
I think we're definitely seeing a shift in practice now that we have so many minimally invasive treatments with more fits on the horizon, increasing concern about the long-term use of medical therapy for BPH, causing longer-term chronic damage to bladders, thinking more emphasis when it comes to BPH, BPO on bladder health. And so I think we're going to start to see this shift, at least I hope, amongst our colleagues in terms of being able to at least identify those men who are at risk for symptom progression, those men who are at risk of having bladder damage, and trying to intervene a little bit earlier. BPH is one of those areas that has a lot of gizmos and gadgets, and I think it's an exciting time to be in the field. And certainly on the surgical side of things, things like aquablation are really proving to be a very good option for men.
Yeah, and I think we've overall learned that BPH is a journey, right? And it's a journey for the patient, and I think it's important for us to define upfront what this journey is going to look like in terms of potential reinterventions and potential changing of path along the way. And thank you, everyone.
Thank you very much.